So I would like to introduce Danielle Ariano from the Division of Reproductive Health at CDC. Her presentation will include valuable insights into the broader landscape of maternal mortality review committees, including her work in tribal maternal health. And that, oh, go ahead and stop sharing, Dawn, and we'll have Danielle pull up her slides. And Danielle joined the maternal mortality prevention team in the Division of Reproductive Health at CDC in September of 2022 as a tribal partnerships and program development lead. She serves as a primary technical monitor for several projects in this role, in addition to seeking out new partnerships to understand tribal perspectives and strengthen capacity as related to implementation of maternal mortality review committees. And so following her presentation, we will continue the discussion about MMRCs to hear from a panel of experts about tribal representation and ways that MMRCs work to improve maternal health outcomes in Indian country. Now I'll hand it over to Danielle. Thanks, everyone.
Thank you, Alicia. Can you see my screen? Okay, great. And you can hear me well. Okay, awesome. Thank you. Good morning and good afternoon, everyone. I am Danielle Ariano, a public health advisor on the maternal mortality prevention team in the Division of Reproductive Health at CDC. And I do focus most of my time on tribal partnerships and program development. And I am joined today by several team members in the room from our program and EPI sections. And throughout, this presentation, I'd like to encourage you to put your questions in the chat as they arise. And then we should have some time at the end for discussion as well. So in the next 20 minutes, we'll move through several topics, but I hope that they'll be helpful in providing, some foundation, background information, and, perhaps an increase in understanding for the panel discussion on tribally led MMRCs that will follow this presentation. So we'll talk about the data that we have to understand maternal mortality. We'll talk about what maternal mortality review committees are and some determinations that committees make. We'll touch on CDC funding and the enhancing reviews and surveillance to eliminate maternal mortality or Erase MM initiative. And we'll also talk about a brief that was published last September about pregnancy-related deaths among American Indian or Alaska Native persons using data from maternal mortality review committees in 36 states. We'll close by sharing our team's vision for maternal mortality surveillance, and we'll talk also about current initiatives with tribal partners. So I have no potential conflicts of interest to disclose. As we discuss maternal mortality today, as Alicia acknowledged, I would like to do the same, that this is a sensitive subject, and acknowledge that there are lives lost behind these data, and each number represents a tragic loss to a family and communities that they belong to. When we're talking about definitions, pregnancy-related mortality refers to the death of a person during pregnancy, childbirth, or 1 year postpartum from a cause that's related to pregnancy. And we see here in the graph that the trend over the last 20 years. And we do see general increases in the pregnancy-related mortality ratio over time. And that the pregnancy-related mortality ratio, or the number of pregnancy-related deaths per 100,000 live births, has remained persistently high. Providing ratios by separate race categories improves the documentation of the disparities that need to be addressed. And we do see racial and ethnic disparities in pregnancy-related mortality. From our most recent data, from 2017 to 2019, there are 32 deaths per 100,000 live births among non-Hispanic, American Indian, or Alaska Native persons. And you can see that in the third bar from the left. So these last two slides show data from the CDC's Pregnancy Mortality Surveillance System, or PMSS. And this allows us to monitor pregnancy-related mortality at the national level. And these data are helpful as they give us a baseline for deaths that occurred during pregnancy or within 1 year of the end of pregnancy. But this system is really limited in identifying specific and feasible actions that can prevent future deaths. And that is the promise of maternal mortality review committees, or MMRCs, to dive deeply and to do so within the local context. So MMRCs seek to provide a deeper understanding of maternal mortality through the lens of both medical and non-medical contributors to deaths, and developing and prioritizing recommendations that may reduce future deaths. So similar to PMSS, MMRCs use death records and any linked birth or fetal death records, but then in addition, they use medical records, social service records, mental health records, autopsy, a variety of other records, and then in some cases, interviews with family members or others who are close to the person who died. Also, different than PMSS, MMRCs are multidisciplinary committees, and they include representation from diverse expertise to really maximize the use of that broad array of data sources in MMRC decision-making. Because of the access to broad data sources and expertise, MMRCs can really increase our understanding of both the medical and non-medical contributors to death and specific prevention opportunities as well. So I mentioned MMRCs are multidisciplinary. We can see here on the slide on the left, the people sitting around the table. They include representatives from public health, obstetrics and gynecology, maternal fetal medicine, nursing, midwifery, forensic pathology, social work, mental health, behavioral health, members of the community, and potentially other disciplines as well. Thus making maternal mortality review a multidisciplinary process that integrates perspectives from all of these disciplines. To give you an idea about maternal mortality review and what it is anonymous and confidential, process of data collection, analysis, interpretation, and action, guided by policy, statutes, and rules. And it really is intended to move from the data that's collected to prevention activities. What it is not is a mechanism for assigning blame or responsibility for any death. It is not a research study, a peer review, an institutional review, or facility review, nor is it a substitute for existing mortality and morbidity inquiries. I think it's important to note that MMRCs do not go back to individual providers or facilities to report on their findings. Reviews are fully de-identified and resulting analyses are shared in aggregate. So for each death, the committee decides if the death was related to pregnancy. They assign an underlying cause of death. They determine preventability and make recommendations for improvement where it is applicable. And these decisions are entered into a standardized data system that we call Maria, and data are analyzed and disseminated to inform action and intervention. So of these three decisions that committees make on this slide, I'll share data around underlying cause of death today, but really wanted to give you a sense of determinations and the variables that are documented in the system and to the circumstances surrounding a death in particular. So these are meant to capture whether the issues of obesity, discrimination, mental health conditions other than substance use disorder and/or substance use disorder actually contributed to the death. The committee may determine that these issues contributed to death when the condition directly compromised their health status. For example, obesity may contribute to a death if it complicated, say, ventilation options for a pregnant person with COVID. Or another example, when we're talking about mental health conditions, impacting a person's ability to manage their type 2 diabetes or some other condition. Discrimination was added to the system most recently in May of 2020. And, discrimination may manifest in differences in care, clinical communication, and shared decision-making, and also encompasses structural and interpersonal racism. And, these components are included based on, the science and the knowledge of issues that may complicate maternal health outcomes and the chain of events leading to a death. So through the enhancing reviews and surveillance to eliminate maternal mortality or Erase MM initiative, CDC is funding work in 40 jurisdictions. In addition to funding for 40 jurisdictions, we also provide technical assistance and training to all review committees. Support to MMRCs has incrementally grown over the past 5 years with additional congressional appropriation and support. And in the next fiscal year, our program does have the opportunity to support any interested maternal mortality review committee nationally. So as the program grows, CDC is working to support American Indian and Alaska Native communities to ensure representation in the data. And in the next several slides, we'll focus on pregnancy-related deaths among American Indian or Alaska Native persons using data from this brief from maternal mortality review committees in 36 states. The data is from 2017 to 2019. So this brief does use a more inclusive definition of American Indian Alaska Native, and this was following best practices for data analysis from organizations such as the Urban Indian Health Institute. The brief was released last September, and it is available on our website. I'm going to toggle between screens here and see if I can drop this in the chat so folks can take a peek at the full brief as I talk through these next slides if you're interested. So understanding differences in the underlying causes of pregnancy-related death by race and ethnicity is important for identifying prevention opportunities to reduce these deaths. An accurate classification of race and ethnicity can be challenging. Acknowledging that methodological decisions about racial classification can affect the size and characteristics of the population used in analysis. Our EPI section on our team approached this analysis by looking to assessments from other groups that demonstrated the importance of examining pregnancy-related deaths among all American Indian or Alaska Native persons, regardless of notation of Hispanic origin or other and multiple races. So this slide describes the alternative approach that was used to classify pregnancy-related deaths among all American Indian Alaska Native persons that was used for this analysis. As shown in this figure, using this alternate approach to classify available vital records information on race and ethnicity, 17 pregnancy-related deaths were classified as American Indian or Alaska Native. So, following the figure across, one death with notation of Native American in the specify other free text field was included. 5 deaths with notation of Hispanic ethnicity or missing ethnicity were included, and 2 deaths with notation of more than one race were included. We do acknowledge that while this alternate approach resulted in the increased identification of pregnancy-related deaths among Native persons, because of known limitations of vital records data for identifying Native persons, 17 is still likely an undercount of deaths. And in the next 2 slides, we'll describe these 17 pregnancy-related deaths. So 16 of the 17 pregnancy-related deaths among American Indian or Alaska Native persons had a known underlying cause of death. And among those with a known underlying cause of death, mental health conditions, which include death to suicide and overdose and poisoning related to substance use disorder, were the most frequent underlying cause of death, followed by hemorrhage. And an MMRC preventability determination was available for 15 of the 17 pregnancy-related deaths among American Indian or Alaska Native persons. And among those deaths with a preventability determination, 93% were determined to be preventable. So kind of to recap the key findings from this brief, methodological decisions about racial classification can impact the size and characteristics of the population used in analysis. The underlying cause of pregnancy-related death among American Indian or Alaska Native persons was mental health conditions followed by hemorrhage. and 93% of pregnancy-related deaths were determined to be preventable. So thinking about, our team and the future, we do have an achievable vision that we're working to realize. For Maria, which is the standardized data system that is used by MMRCs and MMRCs themselves, they'll provide an ongoing, comprehensive, and detailed information necessary for specifically informing prevention activities as the jurisdictional, regional, and national levels. And for PMSS, the Pregnancy and Mortality Surveillance System, it's to provide provisional information on pregnancy-related mortality. So we believe that we will be able to provide information on pregnancy-related deaths from PMSS within 6 months by the end of the calendar year, which will address time lag issues. And although this PMSS data will not be directly comparable to data from MMRCs, it can provide quality, timely information useful for monitoring maternal mortality and for making a limited data set publicly available. And in this vision, both the data from MMRCs and PMSS are universally viewed as reliable, trusted, respected, recognized, referenced, and utilized. But I also want to acknowledge that the vision is not fully realized without the inclusion of tribal nations, US territories, and freely associated states. And that we are in the midst of formative work that is on a slightly different timeline for these populations, as it needs to be, while we continue to hear how this work needs to be implemented to best meet their purposes. So to achieve the goal of serving Native persons' needs and amplifying tribal voices in MMRCs, we began work with the National Indian Health Board to explore tribally led MMRCs back in 2020. At this time, potential models for tribally led MMRCs were developed along with a programmatic logic model. And our team in this work acknowledges the strong basis that exists for exploring the implementation of tribally led MMRCs. Tribally led MMRCs could adapt MMRC processes to reflect community priorities and culturally appropriate approaches. They could provide public health focused recommendations relevant to the community made by a tribally appointed committee. And they could also have direct access to their data and determine use of their data. But in this work, of course, we need input from partners on how a tribally led MMRC would look realistically, and input around what MMRC processes or approaches would work best in and for tribal communities. So with tribal partners in particular, we are funding short-term projects to inform long-term initiatives. There are several projects that are current and new as of this past year. And through all this work, we're exploring the feasibility of tribally led MMRCs and building capacity in current MMRC processes. So we've continued to work with NIHB in policy analysis, convening, and collaborative learning among tribal partners. We're working with the National Council of Urban Indian Health on learning more about urban Indian organizations' engagement in MMRCs and where there are established jurisdictional programs and in potential tribally led MMRCs. We also started working with the Chickasaw Nation. They're implementing a tribal maternal mortality review planning for implementation project. And similarly, we're engaging with Indian health boards, tribal epicenters, and tribal serving organizations, so far including the Albuquerque area Southwest Tribal Epicenter, the American Indian Health Commission of Washington State, and the Rocky Mountain Tribal Leaders Council to explore the feasibility of a tribally led MMRC in their region and build capacity around MMRC participation. So in these projects, partners are exploring and documenting partnerships, data and policy, looking at the strengths and barriers around these components. And so, yeah, just like to emphasize that these are formative activities. We are looking to learn from partners and looking to engage with more partners to improve the program as it exists and inform program initiatives in the long term. So yeah, just like to end there and, thank you for making time and yeah, and allowing me to share this information. I'm looking forward to questions, any discussion. I'll look into the chat to see if there were questions there. Otherwise, looking forward to hearing from the rest of the presenters today.
Thank you so much, Danielle. I'll leave this time for about 10 minutes. If anyone wants to unmute themselves and ask a question or any reflections in the chat, we're open to hearing from all of you.
Yeah, definitely interested in hearing reflections as well. And I am glancing through the chat to see if there were any questions there as we spoke.
Yes, I see one right now. I'll go ahead and read it. It's from Christina. Thank you so much. Is there any current active federal interagency work groups around this work?
So our team does collaborate with HRSA and the Maternal Health Innovation Program. But as of now, there aren't any formal work groups. And I do think that that is a need. I just started this position in last September. So as I'm learning from our partners, I'm also learning about partnerships across the board with with other federal agencies. I know other folks are also on the line from my team, so happy for anyone on my team to chime in with information I might not be aware of.
Hi, Danielle. My name is Candy. Can you hear me?
Yes, I can hear you.
I am from Oneida, Wisconsin. Just recently have been a part of our Wisconsin MMRC. So really learning a lot. What I didn't know going in for it is we're only getting cases of those that had state assistance. So ours is Medicare or Badger Care. Do you know if there's, to me, that's missing. So say something happened to me, I have private insurance, my case wouldn't be looked or reviewed. So do you have a number possibly of those that aren't being reviewed due to private insurance?
That is not an issue as far as I'm aware of. I know that the cases that are reviewed are identified from vital records information primarily. And insurance wouldn't have an impact on that. Yeah, so I'm not aware of that. If there's anyone else on my team that's on the line that might have heard of this kind of thing or concerns from jurisdictions about this, it'd be great to hear from you as well.
So maybe it's just a Wisconsin issue of, they're saying with private insurance, there's a lot more, I guess, hoops to jump through to get records. So those cases are not included.
Yeah, I wouldn't think that would be true for MMRCs.
It's true for us in Wisconsin.
Okay.
So to me, there's many Native women that I know that have went to college, are, working and have this private insurance. So for us here, that would be excluding, almost half of the population in the county that I work in.
Danielle, this is Megan. Do you want me to maybe try to help a little bit, or?
Yeah, happy to get your perspective, Megan. You might be more familiar.
I'll meet you all soon. This, I think, brings up some of the issues we'll be talking about. My name is Megan O'Connell. I am the Chief Public Health Officer for a health board. I think what I'm hearing is it's not that they can't be included, but the difficulties in gathering the data make it such that they're essentially impossible to include. So I agree with Danielle in that the cases are identified generally by vital records, which is irregardless of insurance, but data access issues with MMRCs abound, challenges there abound, and this is just another one. So I guess my answer to the person who asked the question is, unfortunately, I'm not surprised that it would be more difficult to get the data from certain groups of people, whatever that might be, whether it's because of their insurance status or if they go see IHS or that kind of thing. So I don't know if that really helps, but it is a challenge in lots of areas with gathering this sensitive data.
Okay, yeah, that helps that nationwide that's not the case. So it's just specific states, MMRCs, they kind of choose a route that they're going, I guess. So Wisconsin's, it was private insurance. But like I said, it's good to know. And I'm assuming we could take it in any direction. The MMRC that I am a part of now, they said they've had accumulation of, almost 3 years of after being reconstructed. So my next question is, how and if are those recommendations going to turn into actions?
I wanted to give an opportunity to my team to chime in.
Yeah, I can also speak here, Danielle. My name is Tegan Callahan, and thank you for these important questions. I work with Danielle on the CDC Maternal Mortality Prevention team. We can definitely follow up to make sure we're fully understanding kind of the context in Wisconsin. Our understanding is they are identifying all deaths, but as Megan spoke to and as you spoke to, I think data access to the rich information and medical records that a committee would request to abstract and review may be differential, especially for this population. And I think more than anything, this highlights why our team knows it's important to continue these conversations about how an MMRC or many MMRCs could best address the needs of tribal populations in the US. So I think the tribally-led MMRC work is trying to help us better understand maybe some of these challenges and kind of fit an MMRC approach or inform an MMRC approach that would better address the challenges given access to medical records. I think to your follow-up question, I'll just offer that this is really driven right now by the implementers of this work, which is the state jurisdictional authority who we work with. CDC's funding doesn't extend necessarily in all places to implement actions. So I think it may be different in Wisconsin how those actions get implemented than say Ohio or Florida based on the kind of portfolio of MCH and related funding the state partners have to work with. I think Wisconsin just published their first report in the last 6 to 9 months, if I'm correct, from their state-based MMRC. And so hopefully that information is out there better informing and driving action. And we know the program in Wisconsin has tried to incorporate more action partners at the state level, although I can't speak to how much that's actually translated to more action on the ground. So I'll offer that as a first response, but happy to continue to engage. And we can follow up with our state partners too to make sure we fully understand what's happening in Wisconsin.
Okay, thank you. One final question is for the tribal led, it's more of a comment. Just being new on to the MMRC, it's a lot of specific data. You go through the demographics, you go through the health records, but I believe for tribal communities, there needs to be a story included. Interviews with relatives, because they list discrimination as, a contributing factor, but we're not hearing, obviously, the voice of this woman. So that's just a comment out there for the future for tribal led, is that we really need to be interviewing this person's close friends, families, to hear not only, we can't hear her story like CDC's advertisement and new campaign, but we can try to hear her story through others. So that's just a comment.
I really appreciate that comment, and do want to say we do have an informant interview guide available in our resources to state programs. Of course, we would expect that to be updated in some ways if there was a feasible approach to tribally led MMRCs that's identified over the next few years. But I really appreciate that comment. And I'm excited to tell this group that, as we've seen increased funding, we've also been able to provide more support for what we consider a fully comprehensive MMRC, including strategies for informant interviews. And so we hope to see more and more of those nationally. Starting in the state-based programs as well as whatever is to come. I wanted to use that to also address a comment in the chat or a question in the chat about funding and why some jurisdictions aren't funded by CDC for this work. I think there is a variety of answers. In short, moving forward, we will have funding for any jurisdiction that is interested and applies. And so moving forward, if a jurisdiction is not receiving funding, it may be really specific to the context in that jurisdiction. For some reason, they're not choosing to apply. Hopefully that gives you a sense. I think historically, there's been waves of funding. At times it was competitive. Some folks applied and did not get it. Others were not able to apply. But moving forward, we hope to be able to directly fund anyone who's interested and applies that has an eligible program.
Well, thank you guys so much. And thank you so much, Candy, and everyone else for sharing your questions and engaging in this conversation. And thank you so much, Danielle and Tegan, for providing us with that insightful and presentation and background on